Are we live? Hi, everybody. If we can have everyone grab a seat while we get ready. This is the last big panel of the day. So appreciate everyone's stamina at the end of the post-conference. And I do have my phone out, but I promise I'm not tweeting. This is simply where I take notes and keep my questions listed. So this panel comes from a recognition that has been brewing in the sort of data sharing community for a while, that in a lot of cases, data often checks into a shared repository, but is very difficult to check out and actually be reused. And the name of this panel comes actually from the AcademyHealth staff correcting me when I wanted to call some of these data sharing systems roach motels, in the sense that it's often really hard to get data out after it's been shared. And that comes from a variety of reasons. It comes from data use agreements, it comes from consent problems, it comes from technical issues, regulatory issues. And what we wanted to do was put together a diverse set of stakeholders that have worked on either data sharing initiatives that work inside a collective, which Andy Fawcett's going to talk about from Geisinger, or the perspective that a patient advocate might have, which is why we've got Christy Collins here to think about that. Dave Siedzik from the Broad Institute is going to talk about some technological ways that they've been taking on to deal with this checkout challenge. And then Devin, who we're going to apologize, we're going to be beating up on some of these issues, but Devin is here to make sure we understand what the regs actually require. My name is John Wilbanks. I'm Chief Commons Officer at Sage Bionetworks, and I look forward to a panel. Also, we're going to start with just with a couple of introductions. Everyone's going to introduce themselves and their take on this issue. But you should feel free the entire time to raise your hand, walk up to the microphone, and jump in. What I'm going to do is ask everyone to talk about their take on the issue, any blockages that they've seen, what they're doing to deal with those. I'm going to talk about their blue sky ideas. What would they do if they could wave a magic wand and change things and do exactly what they wanted? And then last, we're going to try to be helpful to Devin and others here at HHS and say, what are some granular things we could ask for that would actually help address some of these issues? So with that, we're just going to go straight down the line. I'll ask Andy to kick us off.
Okay. Andy Fawcett, joint counselor by training, and I'm a researcher at Geisinger Health System in Danville, Pennsylvania. As John said, kind of three different topics to quickly hit on. First is kind of what are we doing now and where are we seeing roadblocks. Geisinger created something kind of open notes, which allows our patients to see not only their records, but also their clinicians' notes. On the research standpoint, we're really trying to make research data available. We've really made a decision that rather than the default question of should data be released, the default should be why shouldn't it be? And with our very large biobank, we are returning medically actionable results. I think the difficulty with that is, explaining to people what data you feel comfortable returning and not. As a healthcare institution, we feel that if we return something, people are going to assume that it's healthcare actionable. So we've had a lot of discussions around that. We're also very involved in the ClinGen project, looking at how data should be returned and how labs should share data. With the blue sky, I think one of the things that's really needed are some good tools to help people interpret their data. I think you can give people all the data in the world, but if it's being interpreted incorrectly, particularly when it comes to genetics or genomics, there's a huge risk there. And then anything we can do to help people share their data, because the majority of the genome we don't understand. And then for HHS, I think one of the questions as a researcher I have is how can we clarify what's okay to return from a medical institution, particularly in the sense of raw data? And then I think even the bigger question is who owns that data? If a laboratory does a test on me or a research lab does a test, do they own it or does the patient actually own it?
Devin?
So in terms of some things that we're trying to do now with respect to entities who are covered by Hipaa, trying to spend a lot of time clarifying what Hipaa does and doesn't say. Because what we often find is that Hipaa becomes the shield when an entity doesn't want to share data, even in a circumstance where Hipaa actually allows that sharing under a certain set of circumstances. So in some ways, I feel like our rules both enable Hotel California, because, for example, we don't require entities to share data for research purposes, but we say that you can. And here are the circumstances and some safeguards that you need to think through when you need to get authorization, when you can do so without authorization, when you can waive authorization, sort of a lot of similar things. But there's a path forward, right? But you have to want to be on that path, right? So if you don't want to be on that path, it can become the convenient excuse. So to the extent that many people use HIPAA as an excuse in part because they don't really understand what it allows and what it doesn't, we are trying very hard to get more guidance out there to make clear what it does and doesn't do. Similarly, we are trying to enable some free bird. The place where you have to share under HIPAA is with the patient when they ask. And this has come up a lot today, and I'm really super glad because we're totally proud of those FAQs and that guidance, and we're continuing to develop more of them because questions always beget questions, and we're going to try to be as clear on that as we possibly can. But in that respect, you can't say no. So to the questions, Andy, that you just asked, we have actually in that guidance, there's a lot of it. You actually have to dig into it to find your piece. Some clarity around when you're a lab, what's data in a designated record set. That's a HIPAA term of art, forgive me, but that's the spectrum of information to which an individual has the right to access it and then to share it with whomever they please, or to have that information sent directly to another entity. Ownership has come up a lot today. My colleague on a prior panel talked about how we don't care about ownership. We really don't. If you're a covered entity, whether you own the data or you just possess it, you have to abide by our rules. But one of the things I would add to that is that whether you technically own it or not, when you possess it, you do have an awful lot of control over it. And again, subject to the parameters of law in terms of how you can use it, but there's a huge amount of subjective judgment about how you can and cannot use. So whether you technically own something or not, you have enough dominion over it that if you wanted to port it, you could, save for the laws that we just talked about.
I have a more focused perspective probably than everybody else here. I have a daughter with a rare disease called macrocephaly capillary malformation. She's 6, and about 5 years ago I founded a nonprofit whose mission was to collect data about this syndrome, which 5 years later we still really haven't done because I've learned how difficult that is. And also we want to do it right. You know, we don't want to waste people's time. So our hope is to collect data, collect electronic health records that we can then make available to both the patient and research, so that the patient isn't dumping their data into a hole, that they have access to it. I think that's it.
Any blue skies?
That is my blue sky to
That's
be
your
able
blue
to
sky?
do that. And I actually, so I've been banging my head on this for 5 years, and I just have a foothold in the past couple of months on actually getting it done.
Okay, we'll come back to that then.
Okay.
Go ahead.
So my name is Dave Siedzik. I'm from the Broad Institute in Cambridge, Massachusetts, and we're in the trenches of scientific research. So we're a scientific research institute that's focused on biomedical research. And one of the unique things about Broad is that in its founding mission, there's a value of being uniquely collaborative, and that was a big challenge. And what it's ended up meaning is that we welcome all sorts of backgrounds. And I'm a non-scientist. I'm actually a software guy, and so we have lots of different viewpoints that collaborate, as well as bringing together different consortia and different data types and different research efforts from around the world. And so my perspective is informed significantly by being on a team inside of Broad who's charged with building tools that can actually accelerate the pace of biomedical research and get us to insights and ultimately new therapies and understanding of disease more quickly. And so we've got some real-world challenges we've seen in having researchers be able to access all of this data that we've been collecting and actually use it, not just access it, but use it, and then actually feed that into the feedback loop of further research moving forward. And so we're building some tools internally, but our blue sky thoughts involve a lot more collaboration community. And so part of the reason I'm here is to really learn. We want to do the right thing, and we want to enable the community to do the right kind of science and the right kind of research.
Great. So I'm going to go ahead and I'm going to pull on a couple of threads, but I'm also going to ask, I'm going to start actually back with you, Dave. So can you explain, so there's a project that I'm involved in, this is why I asked Broad to be on the panel, which is trying to deal with the impact of sort of the multitude of data use agreements, consents, and protocols that go in on the collection of data, and the impact that has on the ability to actually share that data back out to researchers. Can you talk a little bit about that?
Actually, I'll go a little bit more broadly first to talk about kind of the big picture of why it's difficult to use data, even though it's been collected. So John mentioned one point, which is actually respecting the patient consents or participant consents in the use of the data. But actually, one of the big foundational issues that we're noticing is it's even very difficult for researchers to discover the data sets that are out there. If they're in the same institution, then that can be something we can facilitate. But there is a wealth of data that have been collected in either different consortia or different national repositories, different state repositories. And then a lot of the data that we're working with is genomic data or other omic data, which requires a tremendous amount of samples and data in order to see the signals that can lead to insights. And so as a result, we need to get our arms around as much as we as a community can to be finding some of these deep insights. So discovery is one of the first big issues that we're finding. Another issue is what John was mentioning, that even if a researcher has a research purpose that is in accordance with participant consents on a given data set, there are actually process constraints and I don't know if there's so much policy, but process as far as being able to unlock access to that data. So it requires committees to meet and letters to be written, and then ultimately when access to data is granted, this very large data that has been submitted to a repository, the first step is actually to download it from the repository, which can take days and requires an infrastructural investment on behalf of the researcher to have enough storage space to keep it. So generally, we're thinking there's a significant value in having a solution, which is what John is mentioning. We call it the data use oversight system, which enables the investigators on a data set to structure the data use, their research purposes that are allowed, the data use restrictions, and then actually have investigators who want to use the data structure that in a machine-readable format so that they can then be matched without having any other committees need to reevaluate the requests. And we found that that a lot of the, I think it's 90% of the consent letters that we have at Broad can be recognized and structured in this way. And we're working on a trial to validate that this can be done correctly. The last point I just wanted to point on, and this is actually a really significant one, is we want to bring researchers to the data rather than bringing data to the researchers. So at that point, that's where we talk about platforms that can enable researchers to not only unlock access to the data, but once they're there, they can immediately begin analyzing that data in one spot. They're not taking it out of the system. It's more auditable. They can do their analysis. They can collaborate with others in the analysis from around the world, possibly, certainly around the US. And then when they're done, they can actually snapshot their insights and share them out to as broad a community as possible. So that's kind of the arc of some of the issues that we've seen.
So that gives us some of the research perspective. But Christy, you said that you feel like you've just gotten a foothold. Can you unpack that statement? Like, what does a foothold mean?
It means I identified. So when I first thought of this, I reached out to Boston Children's, the informatics team, because I was looking at IndivoX. And so I spoke to Mark Natter there, and he's been kind of the one champion of this idea all along. And so I thought I was going to have to build this myself, and he thought I could do that. And I'm a web developer, so I have a technical background, but not quite that technical. And so to do it myself, I need money, and it's a risky endeavor. It's not something anybody's ever done before. There's no guarantee of success, and there's a lot of ways it could go wrong, and I just couldn't find a way to fund it. So what I have found is a vendor, and the vendor has the infrastructure to, I thought I was going to have to hire somebody to go out and get the records. I never thought that I could depend on patients to do that. That seemed completely unreasonable to me. I didn't think that would ever happen.
So why is that?
It's impossible. It's impossible.
So
I mean, maybe if you live in one place and you are a patient in one health system that is very sophisticated. My daughter is seen largely at Boston Children's Hospital, and her health record there is not useful. Her electronic health record there. I mean, I don't want to throw anyone under the bus, but it's complete. To be honest, I'm always surprised that people talk about this like it's a real thing.
Right. Well, that's.
So
I mean, we're talking about a blockage. Like, that's the most depressing blockage we can hear about.
Well, but you know, the other side of that, I think maybe if you're in the VA, maybe you have a smoother transition. But you know, I'm dealing with a specific kind of population. They're like medical gypsies. They go all over trying to, different specialists in different institutions, or even just trying to find an appropriate care team. You might go all over the place. I know we have. And then, some of your providers are small providers that don't have an electronic system, and some of them are big, sophisticated hospitals, and none of this stuff talks to each other. Kids like my daughter are Medicaid patients. They're not in an insurance system that's providing their health record.
Right, so you might be able to check data in, but you're going to be checking in a bunch of different PDFs that are not synchronized or harmonized and are hard to use.
Well, to be honest, I never even got to the point of figuring out how we would manage the processing of that data. I thought if I had to hire somebody even to go fetch it, like just that, and then myself. So now I've built a full-time job for me. Now I have two full-time employees. Forget about, anyway, it just became a software project that I didn't, we have a patient population of, I have a database of under 200 people worldwide. A few years ago, I applied for a PCORI grant. We had 65 people in the United States. So the minimum number of people for the PCORI grant was 50. So I had to say, okay, I'm going to get 50 people out of my 65 people to participate in it. So it's a very small patient population.
So I'm asking these in intentional order because I was trying to set up Andy, because I think Geisinger, I'm sorry, it's no secret, I'm a big fan of Geisinger's work here. The EHR work you've done, particularly matching to genomes and biobanking, what did it take for you as a health system to get to where, if you are a patient in there, you can actually have a well-structured, usable piece of information, both as a patient but also from a research perspective?
Well, I think it definitely took an institutional discussion that openness and transparency was important, and that I'll go back to the kind of the clinical work, which is the open notes, that there are kind of two goals with that. One is that it improves conversations between the clinician and the patient. The second, it actually improves conversation between clinicians and clinicians, because one of the things we found is the notes got better when the clinicians knew somebody was looking at them, and a lot of miscommunications. But I think it's just setting up that information should be available, and there's still parts of our record that we're working on opening up. I think on the research standpoint, we looked at it because we are primarily a healthcare organization, that if we're doing research, that what's the healthcare benefit back? So if you have, I think in genomics, particularly now that we're moving to large gene panels and exome sequencing and other things, there's medically actionable data in anybody that you put in a research project if you're looking at. Now, you may not be looking for it in your particular research project, but the data's there. So how do we put the infrastructure to be able to return that? And then I would just go back to kind of what Christy said. I have done a lot of work outside of Geisinger with patient advocacy groups of really empowering the patients and getting them. A lot of people complain about patient-reported data, but patient-reported data is much better than no data. And then also I find that often the clinicians are kind of afraid to share their data because I'm going to write this up someday. And I'm like, yeah, if we can get across the message that if everybody were to share data, we're going to get those answers much quicker. Because I still think there's some resistance, particularly from the individual clinicians and the smaller researchers, to share that data. they don't realize that they'd actually get their own paper written faster if they were to share data than keeping the data themselves.
So, Devin said something, you said something in your early comments about how Hipaa gets used as a shield. And so when I hear Andy, I actually want to hear all three of the other panelists talk about what they're doing. None of them are using Hipaa as a shield, right? Everyone is aware of sort of the reality here. How do you get awareness of what's actually in the regs out to the holders of data?
So this is hard. We're scheduled to do webinars for various professional associations. We sit down with them on a regular basis to provide updates on what we're doing, and we've done presentations on the material. We're continuing to do presentations on the material. We're continuing to reach out. We're going to be doing a module that is available for professionals to take to get CME credit, to learn more about the right of access, because people like to get their CME credits. It's a very helpful tool out there. It costs us some money, but it's money well spent. We have modules about Hipaa generally that have done very well out in the marketplace. We put material out on our website. It's pretty voluminous. And as Jocelyn, if you were here for her morning conversation, apparently it is sleep-inducing. So we are working with ONC to try to create consumer-friendly materials, because if there can be some consumer demand for this, people can understand that they have this right, and that when they're told by an entity, no, HIPAA doesn't allow you to have your data, which still does happen to people, or people get told, well, yes, you can have it, but you have to pay me $500 first. But I think ultimately we have this other part of the Office for Civil Rights, which is our enforcement division, which we're going to be deploying in the space of access to make sure that this right gets realized. We would much rather have voluntary compliance, but appreciate that what we're trying to do is lay a platform for culture change, and that's going to take some doing. And we're open to ideas, actually, about how we can get out to people more about, it's not your choice to share data with patients. You must do so. And you must do so in accordance with our rules. And by the way, if you want to make it easier than our rules require, please do so. Because this is where healthcare is going. We're trying to ride that wave and be part of it and encourage it.
Well, so, and this is a question for everyone. First of all, any questions from the audience yet? Got to have some questions for these people. Okay, I'll keep going. So a previous panel, there were some interesting comments about how we're beginning to be able to generate this data almost completely outside of the regulated space. I've spent a lot of time working on clinical studies that use apps to do this. But from each of your perspectives, if you actually wanted to share the data back out to researchers, would you, and you were given sort of a small pile of money today, would you build something inside the system or outside the system? And we'll start with Dave and work our way in. If the goal is to get the data out to researchers.
So I think we think of it in a little bit of a different way, that we're not so much getting data out to the researchers, because we are the researchers, so we want to figure out what the appropriate ways to get data into the research community would be, and then how to actually establish the right kinds of collaborations to do collaborative research. One thing that we have been working on is under the umbrella of the fact that certain data are actually pretty hard for us to collect in the traditional research sense, especially from rare disease populations and rare cancers and smaller populations, that we're actually working directly with patients to say if they want to contribute their data to a research project with the right kind of foundational consents and the right mechanisms for engaging them in dialogue, then that's something that we're actually building so that we could start studies that way. And we found that's just a really important resource to the overall community, as well as to the community of people who have data that they want to contribute and know that it's going to contribute to the impact ultimately. Is that inside or outside of the system? I think we're not, it's not clinical data that's being provided to us right away, but there are certainly things we're going to be encountering on that path. So this is where I'd like to hear from everyone else as to what the solutions are there. But that's been kind of the other piece of the puzzle in line with how do you do the research really quickly, how do you collect the right kind of data and enable the people to contribute in a way that can ultimately create impact.
Well, we considered when we first started the organization, not starting the organization and trying to get a university or someone to start a registry on our behalf, and we decided not to do that. There were too many things that could go wrong. The incentives were not patient-centered in that scenario. And so even though it's been so difficult that we haven't actually done it yet, I still think that that was the right decision. So I would stay outside of the system. I appreciate being outside of the system, even though it's hard.
Devin, I'll absolve you of this one.
Yeah, I'm not allowed to do anything outside of system.
Right. But that's actually a really important point. When we talk to the government folks, it's nice to be like, why can't you fix X, Y, or Z? Devin doesn't get to wave a wand and change things. Although if maybe we buy a drink later, we can ask her that question off camera.
I would say that our goal is to try to build it inside the system, and the reason for that is that it may have potential benefit for that person inside the healthcare system, and if it's outside the system, often it's then not available to their clinician when they come in or whenever they're having a visit. So I think if there's a way that you can build the data where it's available easily to the researchers and it's also available inside the system to the patient and to the clinicians, and that's kind of the way we're doing with our sequencing study, so that the information is research information, but then when we find things that are clinical, we clinically confirm them when we make them part of the record, so that it is available for both groups. And I think that's important. I think it's also important when it comes to recruitment and others. Probably many of us in the room believe in research. That's kind of why we're here. That's not necessarily true for everybody in the world. So one of the questions is, what's the benefit for me? So you take precision medicine, we're going to ask these people to come in and do an evaluation and other things. So if we can capture that and put it in their medical record, then it may be something that's beneficial for them health-wise. So that's been our goal in our discussion, is bringing it inside so that we can make sure that it also benefits the individual while we're trying to benefit the researcher and the greater population.
Well, and this is something we've seen at SAGE in our Parkinson's study, is that the people who are participating want access to their monthly sensor data so that they can show it to their doctor and have a conversation about how the research study can inform their care completely outside of the study. Yeah. Right? So if I can download my monthly data, take it to my doctor, the doctor can look at that and say, oh, every time your sensor data is dropping, it appears to be because you're not eating, or you're watching the news and you've reported that as a stressor. So it changes the beneficence voluntariness aspect of research if the liberation of the data to the individual can affect their care in ways that we don't really understand yet. There we go. That's the line I'm.
Prescription not to watch the news, right?
That's right. Well, we can't return that because then we'd be a regulated medical device. But Adrian, please.
I want to go one step beyond the question that you just addressed and ask this. Within Hipaa, there is no accounting for disclosures right now for things under TPO as a requirement. But to the extent that the data is being used under patient authorization or consent, whatever you want to call it, for research, there would be such an accounting, I understand. And so from your perspective, particularly Christy, but maybe the others, would going in the direction of pushing hard for an accounting for disclosures for the clinical uses be a good step, or would you think that keeping the research uses separate and less threatening in the business sense of the institution is better for what you're trying to do?
I'm not sure I'm following your question in
other
terms
words,
of...
Industry has, the healthcare industry has resisted introducing accounting for disclosures, real time, the way we get from a bank, let's say, or from a commercial merchant.
I don't know what accounting for disclosures means.
It's a list of disclosures from the medical record. Like anytime information went out of the medical record, where did it go?
I'm sorry.
No, that's okay.
That's
okay.
So I'm asking, would that be helpful because you would be more plugged into the clinical uses, or would it be considered obstructionist and you'd rather have the research uses be sort of separate?
Being concerned about the accounting of disclosures sounds like I'm worried about privacy. Is that what you're getting at?
The data changing in that children's EHR without you knowing that it changed or that it was used?
You know, our biggest concern is that the data is not used. I'm not really understanding I'm not understanding your perspective, but what I can tell you is like that it all just feels like a colossal waste, because every rare disease patient feels like they know something important and they have no way of sharing it. That's the biggest concern.
Perspective is simply transparency. I guess.
I'm not sure that people in my position. I mean, I can only really speak for this very specific kind of condition, but I don't think that is really the concern. Although if I could take the opportunity, once you kind of mentioned integrating into the clinic, wow, that would be so much better. I mean, the Mark, who is sort of a mentor for me, he had shown me the New Yorker article about the Cystic Fibrosis Foundation and how they have built care around data. And so I guess that is a combination of the foundation and the clinic. And to me, that is, I don't understand why everything isn't modeled on that.
And I'll just add one point back to your question. I've talked to lots of rare disease folks, lots of patient advocacy groups, and you have to weigh is increasing the transparency going to slow down the process, and is it going to spend money that could be spent on research? And whenever you ask it that way, what I always hear is make the data broadly accessible, don't slow it down, and don't add cost that don't increase research. So I think, I'm not saying that we don't need more transparency, but I'm saying that we have to balance the two. And what I've heard from the individuals who want that research to happen is if they had to choose between the two, they'd choose between not having the transparency, not having the recording of every time it's looked at, just want to know that it's looked. And that's actually one of the questions we get from people in our biobank is, has my sample been used? Has my data been used? They don't really care who's used it. At least they haven't asked us that. They just want to know that it's being used.
Hi, my name is, wow, that's loud. Lily Bragg. I work for Burst IQ, which is a cybersecurity company for health data. And I am actually I believe that we are going to get to a point where we are able to actually liberate the data. I think we're on the cusp, and I think it's awesome. On the flip side, I'm terrified of what will happen next. There's been a lot of focus and energy, and I think rightfully so, on that first step of getting the data out of the systems. But then once you have the data out of the systems and in the hands of the patients, of the uneducated patients who don't know about the security challenges that it will take to control that information and to actually keep it safe so that you don't end up with individuals who have ransom issues with their own health information. Is there anything happening on the regulatory side that's starting to anticipate that component of it when we do have the data out and people want to have it on their own home computer and then not get hacked and have their social hacked and have all their biometric information hacked, et cetera?
Are you allowed to say?
Yeah, well, so I think you raise a really good point. I will tell you that we fought very hard when we were working on this access guidance, and still, even when we're talking in other discussions about making sure that individuals, for example, can get access to data even that's generated in a research context, not just data that's generated in a clinical context, that people do worry what's going to happen to that when it's in the hands of people who know sort of a whole lot less about how to best protect it. And there's lots and lots of talk about how to give people tools so that they understand how to evaluate various ways of holding their data. You brought up the issue of individuals being, subject to ransomware attacks, which, at least if you read the trade press, is something that feels like it's unique to the healthcare industry, but it's not. This is happening already today because most people don't think to back up their own data. So then they're vulnerable when they do an attack that is demanding money, and they don't want to lose their family photos. They don't want to lose this valuable data for their child that they've been collecting from many things. I don't think that should stop us from pursuing this, and I don't think that's at all what you suggested. But I think you're right to raise it. One of the challenges about how to approach that problem is that we do tend to regulate sectorally in the US. And what's the sector for individuals' own computers? We don't have it, nor do we typically regulate how people handle their own data. So I think it's an enormous challenge. We're dealing with it now through education. but that's probably not sufficient in the long term. I think you're right.
Weigh in on tools or other things?
Well, I think that's one of the big considerations for our vision for making sure that researchers come to the data rather than data coming to the researchers. So it's not so much about what happens when patients actually request the data and keep it on their home computer as much as it's if someone wants to contribute their data to research, does it have to flow through that literal chain of custody to say, here, we're going to hand it all to you, or are there ways to keep the data in good technical hands and then put it in a place where researchers come to it rather than having it go places that can't be audited? That's one good question I'd like to then pursue.
One of the things that keeps coming up in our work is the idea that there's one copy of the data is often one of the hardest things to get people past, which is that there's a copy that's in the research stack, there's a copy that gets returned to you as a participant, right. There's a copy that's over, that gets federated into, LaTanya Sweeney tracked this, right? 100 people get a copy of a record the minute it goes into your EHR, right? So this is where the concepts of ownership and control start to blur, because it's, is there a copy that's being used? Is there a copy that's mine and then I can take out? Are different questions than what's happening to my data.
Dan Barth Jones, Columbia University.
Hey, Daniel. It's nice to meet you in
person. Hi, John. Nice to meet you. One of the things that I think liberates data but is dramatically underutilized is the limited data set allowance under Hipaa and the ability to use for special purposes of research, public health, and healthcare operations, data under a data use agreement. The reason why I believe that's largely underutilized is because it requires execution by the covered entity to the data recipients. And that creates a logistical overhead in terms of getting all of those data use agreements executed that sometimes causes people to go to the route of de-identification, which in some cases can destroy more data utility than is present in a limited data set. So I guess my question is, do people on the panel have any thoughts about how we could make that mechanism better utilized? Is it within the realm of feasibility to contemplate that business associates might be able to also execute limited data set agreements with others?
Well, that's sort of, so a limited data set is a particular vehicle in Hipaa. That's one of those research pathways that I alluded to earlier, ways that people can use data with fewer constraints because it requires execution of this agreement, requires some identifiers to be removed, but not all of it. Often underutilized. I completely agree. One of the things that I think policymakers, and this really goes beyond sort of Hipaa because my guardrails are set in legislation, but if we did probably a better job of thinking about regulating holders of data versus requiring contractual commitments necessarily to make sure that the chain, the data is protected on down the chain, and it's sort of more of a data protection model like they pursue in other countries, we wouldn't have to depend so much on execution of multiple agreements, whether it's enabling a business associate to create limited data sets, which by the way they can, as long as their business associate agreement lets them do that, but that requires a contractual commitment. So and oftentimes entities are worried about allowing too much freedom downstream from the data they provide for lots and lots of reasons, whether it's liability fear, whether it's concerns about loss of proprietary interests in the data. I mean, all of those really come into play, and privacy becomes the piece that gets talked about when in fact there's usually a whole constellation of issues that are involved. So, we put that out there in terms of our own education. Here's a vehicle you can use. You don't have to fully de-identify the data. It is used by some entities, but not by others. But I do think if we think holistically as a society about, is that sort of the right model to make sure that data is available for all the reasons we need it to be available, but while still providing some protections so that people trust it? Where's the trust triangle from earlier today? What's the best way of achieving that? I'm not sure we as a society here in the US have arrived at it, and I think it's worth constantly thinking through whether, are we in the right place about
Well, yeah, I
this.
mean, in the culture we live in, contracts that stand in the way of functionality that's desired tend to get clicked on without being read or road graded, right?
Well, right. And how are you going to enforce like multiple agreements? It's hard.
Thanks.
Hi, Anna McAllister-Slip. I have a question for Devin, I guess, but anybody else who has insights that they can provide would be helpful. How do we get beyond access and being able to see our data in a PDF form and the work that you guys are doing within the OCR and Hipaa and all of that around clarifying access to getting it in a usable form? And as somebody who's, a patient advocate, multi-layered nerd who, knows lots of other people who are really interested and passionate about this, PDFs don't really help with research. They don't help with me putting the data into a platform that's going to integrate data from multiple sources. So is this something that we currently have the legislative authority, not being me, but you have the legislative authority? Is it something we need to go to Congress for? Is it something that we need to email Secretary Burwell about? What are the steps that we need to take to make sure that the data is usable, not just viewable?
Right. It's a really good question, and I apologize to my fellow panelists. This sometimes happens when there's a regulator on the panel. It's a great time to sort of get some of these regulatory questions aired, and then I end up taking up way too much real estate. So I'll try to say briefly, we did in that guidance, in the patient access guidance, say what the patient gets is the information in the form or format that they want, as long as the entity can readily produce it in that format. So that means that if it's being held in a certain vocabulary, type a data standard, and that's what you want, and you want it to be able to download it in that format. So I think we probably have more we need to say about this, but if you're being defaulted to PDF when in fact the data is being held in formats that you're trying to get and you're being told no, that should not be happening under our new guidance. If they hold it in a format that you could use and you're asking for it in that format and it's not being given to you and you're being, again, defaulted to PDF, which is not useful for you, that's a problem. In some ways, this also ties into how the data is being kept within the institution, unless there's a piece of it that I'm missing. We want you to be able to get what they have in the way that they have it.
I understand limitations you're working under, but that is a lot of work. And half the time, the people that you're interacting with have no idea what it is that you're trying to get and why to get it. And I actually had a couple of friends who had children seen at the NIH Clinical Center do a test case for me within the context of all the PMI stuff of trying to get their child's data in a CSV or Excel format.
Right.
Super simple, and it was impossible. Not because the people didn't want to help, because they had no idea how to do it or what it meant. And by the way, this process took weeks, lots of emails and phone calls, and it still wasn't successful.
Yeah.
So.
Yeah, we really want to get that kludginess out, and so we are absolutely open to suggestions from you all about how to do that.
Okay. Devin, I think you're going to be off the hook on this one.
Oh, good.
Andy, I'd like to ask you a question about the Geisinger system and what the turnaround time would be for a patient at Geisinger who wanted to get their data and then give it to, say, send it to a third-party app. What would the turnaround time be?
Depends on what kind of data you want. For medical visits, right now, if you are signed up for the patient portal, you can download any visit with all the collected information in that visit, and you can send it anywhere you want. That's available. My understanding is with the next Epic update, you would be able to do that for your record. Right now, you have to be cautious with Epic because it's worse than Microsoft operating systems in the different versions.
Honey, I know
but we're not on the latest version, but we're working toward that, but understand. So I think that would be as soon as. Now, I think if you aren't in the patient portal and you
can you give me a time frame? Would it be
I can do it now. I could do it right now. I could go over there and sign on the web.
It could be
in real time.
Minutes. In real time. Okay.
Minutes. Yeah, I can go over to the computer, sign in on my account. I can take any visit and I can download an HTML file or a PDF, but HTML might be more, and I can send that anywhere I want right now.
Okay. All right.
Yeah.
Thank you.
Now, what they're trying to do is get where that would apply to things like X-rays and MRIs and CTs.
Yeah,
and,
that's the challenge.
the problem
isn't
for
it?
that is the data file size. But they're working on it. It is on the list of trying to do, where not only could you send it, but you could also, as a patient, go and actually look at it. So.
Dina Shancer from the Public Health Agency of Canada, and just had more of a comment. I can see sort of the last one here with questions from the floor. I do a lot of research on administrative databases, so secondary use of data that's collected throughout the hospital. And the question of making data available for research, I do see a lot of research coming out of the U.S. from some of the larger, I guess, insurance companies, payer groups and stuff, which actually links all the physician visits and the visits and the hospitalization records and mortality in some cases as well. Sort of very envious. We're just starting to do some of that with our own records. But generally on the question that you were posing earlier for research, I suspect that most of the data sets that you're talking about, you can liberate them for the patient themselves, but they're really too small for a researcher. And that what's required is an infrastructure. We have some experience with that at the provincial level, but even in Canada, there's a lot of movement, and so if you just limit it to one province, you're going to have a lot of loss to follow up. So that you're really, I think, looking, okay, well, if you're looking at research as one of your objectives, probably just see, okay, well, what systems and what countries and what infrastructure is actually needed in order for some of that research to flourish. And that may be a question that, in all the innovation that I'm seeing here, that may be a gap that you may want to look at in next step and sort of look at that major question of what infrastructure is really required to promote research in some areas. And I think there's big differences from one country to another. It'll really depend how easy researchers have access to some of that information. So that's just a comment and a thought that after hearing you discuss some of that it is a big step, and it may be a little bit out of your reach with the small size that you're looking at the moment.
Christy, since you said you found a vendor, what are the features of the system that you're going to pick up?
The user interface was really important to me, that the patients would have, so we were talking before about, do people have this on their computers? I never imagined that patients would have this data on their computers. I imagined a cloud system where they would log in and have, because, I mean, what do you have on your system? A big CSV file? You know, it's like impossible. You need an interface where people can make use of it. So that was a very important thing to me. And then the other thing was that they were interested in working with us to export data for research. And so, but that's kind of where we're at now. I know that they have those two components.
What are the core features of the interface that you're looking for? What are the core actions you expect someone to do?
Well, one that was really exciting to me about this one is that you can view MRIs, imaging files, which I think is amazing. I mean, most patients can't view that on their own system. You know, I've done it, but but most people can't figure out how to do that, I think. So that was that impressed me a lot, but also just actually even in DevoX, when I first installed it and started trying to use it, it seemed like a bunch of containers that didn't make sense to me as a patient. I can see how they would make sense to a hospital system. And so, you know, I haven't spent a lot of time with this other product, but to me, that is one limitation I've seen in the implementation of other personal, you know, the way things are framed. I'm trying to remember some of the lingo, but it's like not lingo it's not jargon that patients would understand. It's like specific to the hospital, to the industry. It's not patient-centered.
So we've got about 5 minutes left, I think. So I spent most of the last 2 days asking people what they would ask HHS to do, and I picked my favorite one, which is actually from Adrian, which is, and this is to Devin, although I don't expect you to have to respond, which is, what does it take to require that data holders accept digital signatures? Because right now, they're allowed to accept digital signatures, but they're not required to, and that's often used as a shield. Yeah. So that's my favorite thing I heard this week. If I could wave a wand and change something, it would be to require that data holders accept digital sigs.
Yeah, that's, you know, there are lots of ways that you could sort of address the kludginess, right? That's one obstacle point. There have been many others that have been mentioned, is to say, no, you don't have a choice anymore. You have to do this, right? That is definitely one approach. It's a harder one for us to adopt because there are sort of limits to where we can take our regs. And another approach is to say, look, if we've got the incentives right in the system so that sharing becomes the norm and is something that people want to do, and maybe that's too much of an ask, but if that were the case, then all people would need was the clear permission from a regulator that you can use a digital signature, and they would take it. All people would need is a clear indication from a regulator that it's okay to use this particular methodology for authenticating individuals in an online transaction, and it would happen, right? The latter piece, where we sort of understand where people have misinterpretations about what they can and can't do, and where we can try to bless certain ways of moving forward, that's a piece we can do, and that is a piece that we're trying to do, and that's part of conversations that we have with ONC, with our partners within the federal government, including the FTC. It's like, what's going on out there? Where are the hiccups? And to what extent can we smooth some of those over within the authorities that we have? But if what it's really going to take is sort of, no, that you don't have a choice anymore, you must do. I mean, we have the must do with patient access, but must do in terms of you must take a digital signature, you must accept, you know, the following types of communications, whatever they are. That's just one example that you provided. I'm having a brain fart. Can't think of another good example. But that takes that's a lever that we may not be authorized. We may not have enough authority to pull. I mean, it just depends on the circumstance.
But could you?
Thank you. I'm sorry to put you on the spot like that, but
no, it's okay.
But one quick kind of maybe in between, could you quickly state, make it very clear and very public that digital signatures are okay, and then switch the default, so an institution, instead of having to justify why they use a digital signature, that their patients go to them and they have to justify why they can't.
Well, we have set that up already. We
Okay.
have set that up already. So again, HIPAA's a bunch of permission slips, except in the case of sharing data with patients, where with very rare exception, it's a must do, right? And we've tried to provide some clarification around, it's the form or the format that the patient requests, as long as it's readily producible. We tried to provide some examples of what that meant in certain contexts, because it's not readily producible, meaning, well, this is how I want to do it. It's readily producible in terms of this is how you can do it. And so the issue of, digital signature, can you take a request from a patient by email? Yes, we said that. This is why we did FAQs, frankly, for this patient access, because we wanted to keep adding to the pile, thereby making it somewhat hard to find it, but still, like, trying to address every single one of these questions so that to the extent that to at least eliminate that uncertainty.
We have 1 minute, so you're going to get the last word.
I actually have a question about the digital signature. First, I love what OCR is doing, but when you raise the digital signature, to me, it just, and I'm Amy Sheffrin from the New York State Health Foundation, it just sounds like another hoop, and it's not for the real world, because sometimes HIPAA is being used in a way where, a daughter, a son hears that their parent is in a hospital, they're in another state, they call the hospital, they try to get information about their parent, and the hospital says, we can't share it because of HIPAA. So it's not so much about a digital signature, it's more about can the healthcare providers feel that their frontline workers deserve the judgment and discretion, and that they have enough of the professional training to trust that when they give information to a family member, it is for the right reasons, and that they won't put their job at risk, that HIPAA's not about protecting the institution, it's about serving the patient. So digital signature, those sort of things, you're creating more hoops. It's all about just however a patient, as Devin said, how a patient needs it when they need it. Thank you.
And we're done. We got to get off so we can make room for the next panel. Thank you, everyone. Thanks to the panel. Good job. Thank you, Devin.
So your program says that we have 10 minutes of closing remarks, but we tricked you because we wanted to make you really happy that you could leave a few minutes early. So all that's standing between you and happy hour is me and my 2-minute closing. And so I promise to be brief. For those of you who've made it to all now 3 days of Health Datapalooza in the room, online, thank you so much. We really appreciate it. For those of you who just got to catch this event today, also really grateful, particularly for staying through to the bitter end. This is the first time, as I think some others have noted, that we actually broke up the program so that there's a whole day dedicated to privacy and security issues. We would love your feedback. So please tell us what worked, what didn't, how can we improve. That holds true for today, for the whole meeting. And I just want to give one more round of applause to our tremendous panelists and speakers. And to all our colleagues at HHS who helped us to pull this off, but especially, even though I know she's no longer in the room, Lucia Savage and Devin McGraw, who were just tremendous. So thank you.